Thanks, Sergio, and thanks to Actinium for inviting me. So there's lots of ways that we're going to hopefully improve the outcome of adult ALL. First of all, targeting MRD persistence post-induction, usually after 2 phases of therapy. We need to more aggressively target the very high-risk cytogenetic groups that are listed there. Clearly, many of the new agents have targeted relapse with the goal of getting more people into remission, getting them to a transplant in better shape, and then doing a transplant in a less toxic way. It's not proven yet, but it may be worth looking at molecular relapse post-allograft. We might be able to modify that. And finally, now, as we all know, we have therapies for totally refractory ALL. So where we're going is individualised or personalised care for patients with adult ALL. And this means adapting pre-transplant conditioning to fit in with the patient in front of you, their comorbidities, their age, and their risk of relapse. So what that means is adjusting GVHD prophylaxis, perhaps the stem cell source, but also definitely the post-transplant immune manipulation. So the risk of relapse, of course, is determined mainly by cytogenetics, but also the post-treatment MRD status. So here are some indications for allograft, and I have to say they're evolving and there isn't universal agreement. This is, first of all, in pre-B ALL. It's quite accepted if you're MRD positive after 2 cycles of chemotherapy, you should have an allograft. High-risk cytogenetics, I would say, irrespective of MRD, that those patients are worth considering. A long time to achieving CR1, that goes back to the Holzer data 20 years ago. What I think is new is that the outcome of adult ALL in the older age group remains still quite poor, and I'll show you some data suggesting that allograft has a role there. Where I think we're slightly changing is that a high white count alone may not be so much of a reason to proceed to transplant if that patient becomes rapidly MRD negative. So this is just out in Blood this month, a review that I and Claire Roundtree have done on T-cell ALL. So there are 7 potential indications for transplant there, and I think the first 4 are no surprise to anybody in the audience. They've been defined in the largest T-cell studies, including from our group. What's a little bit newer is that we realise that early T-cell precursor ALL in adults has a poor outcome. We lack the data to know that allograft improves that outcome, but it's certainly worth considering. All of you, I hope, will have read the really important data from Graal on the oncogenetic classifier, looking at NF and PTEN and RAS genetics. That clearly sets aside a group who should be allografted. And again, I would suggest that age is another reason. It isn't quite so common to be in that age group with T-cell ALL. So just to sort of give you a flavour of where allograft may play a role in ALL, now, it plays a bigger role in the UK because we've got some specific transplant-associated questions. But our trial is just about to close, UCAL14. It's going to be about 750 patients, and over 400 will receive an allograft. So this is what we've done. If they're less than 40 and have a sibling donor, they're offered an allograft. It's not mandatory if they're MRD negative. They get an unrelated donor transplant if they're high risk. We define being above 40 as high risk, and irrespective of lineage, they're offered a reduced intensity allograft if they had a high quality donor, as defined on the slide. If they were very high risk with adverse cytogenetics or were MRD positive, they could have a 7 on 8 unrelated or a cord blood transplant. And this is what it looks like schematically. So there are really 2 parts to it. There's the rituximab randomization in pre-B, then the niraparib randomization for T-cell disease, which will continue into our next trial, and then divisions of transplant based on age, above or below 40. So let's go back to the original question, does conditioning actually matter in ALL? Well, there are data that allograft is more effective if there's good disease clearance or indeed MRD negativity, both in children and adults. However, pre-transplant chemotherapy interacts with the outcome of transplant, and prolonged toxic chemotherapy can result in infection, including invasive fungal infections, organ dysfunction, poor Karnofsky scores, and I think a higher TRM. And you will still see series of allografts in ALL with TRMs of 25% and above. So this is a study that I bet many in the audience have not read. It's a study that I did with Steve Foreman and Carl Bloom and the CIBMTR Acute Leukemia Committee about 10 years back. And probably many of you in the audience use this regimen. What we did is we compared cyclophosphamide and VP16, and we looked at TBI doses above and below 13 gray. I would say the world standard is cyclophosphamide and TBI of about 12 gray. Well, if you look at leukemia-free survival, the other three are very much the same as each other, but there's clearly inferior progression-free survival in this group. And it's not a small amount, it's about 15%, and the reason it's lower is relapse. And I never use this regimen. If you do a study like this and then don't believe your own study, that would be a pity. So it isn't all about conditioning. We're obviously aware that there's an important GVL effect. And this is a very old CIBMTR paper that I participated in, Jacob Passweg. And long story short, grade 2 to 4 acute or chronic, if you had either of those, there's a 2.5-fold reduction in relapse risk. It's very powerful indeed. So, to look at our reduced intensity data from UCAL14, just going to highlight a few things. We've actually expanded this group to 160. I don't have complete data, but I will talk a bit about it. So, median age 52, 3/4 B cell, and predominantly unrelated. So, about half of them high risk. Most of them came to transplant MRD negative, and they had a good performance status. And this is the regimen that I think is fairly well known worldwide, fludarabine, melphalan, and alemtuzumab. So we used 30 in the sibling group, 60 in the unrelated group, and then we followed it with intensive surveillance of multilineage chimerism, because mixed chimerism is common, and assaying molecular MRD. And these are the results. So now in an expanded set of patients, in fact we're up to 160 now, and it's really just the same. With the 2-year median follow-up, the progression-free survival is a bit short of 60%. And I think we do have a plateau for TRM now. Again, at 2 years, it's about 18%. Nothing is ever quite good enough, of course, and maybe this is what one expects, but we had hoped for slightly less relapse, 27.5%. In an expanded data set, I can confirm it's still very much at this value. We were worried by those 2 late relapses, but they don't appear to be continuing. So to look at relapse in more detail, 27 patients, the timing was just short of 8 months. With this small numbers, it wasn't associated with high-risk cytogenetics. We need to look again in an expanded group. What it was associated with very clearly is MRD positivity at the time of transplant with a hazard ratio of 2.4. So this is going to be our strategy in UCAL15, which we're currently devising. We clearly need to get more patients to transplant MRD negative. We're going to look at intensifying conditioning, especially in the MRD positive group, possibly busulfan, possibly a reduced dose of TBI, similar to what the German group are doing. We will reduce alemtuzumab doses and mandate early cyclosporin withdrawal, but we're also going to look at DLI. There's a bit of a suggestion that some MRD negative patients can be turned around with DLI, but there are a range of other options that we need to explore, including second transplant. There really aren't good data in ALL. So to move on to myeloablative transplants, again within UCAL14. At this stage of analysis, we had 75 patients, median age of 31, again, half high risk. And to look at the basic transplant parameters, they're fairly standard. A fairly low incidence of grade 2 to 4 acute graft versus host disease, 22% TRM, and a 25% chance of relapse. The major causes of death, of transplant deaths, were GVHD and infection. And this resulted in event-free survival of 60% at 2 years. And these are what the curves look like. And I think there are 3 plateaus here. TRM, relapse, about 25%. And I think what's going to be a stable plateau of about 6% event-free survival. So can we do better? Well, these are data from Parto Kebriai. It's a study that we've been doing with CRBMTR. We're going to hopefully send it off soon. But also, we've got to acknowledge Claudio Anicetti and the City of Hope group, comparing TBI-based regimens and intravenous busulfan regimens. So, of course, there are some differences between the two groups, and the ones I think that matter are highlighted in red. So there was more TKI use in the intravenous busulfan group. However, there were more patients who took a longer to achieve complete remission. A bit more use of peripheral blood, quite a bit more use of in vivo T-cell depletion, but also they're in a later time cohort. These matters are all adjusted by a multivariate analysis. So, concordant with the AML data that I'm sure you're all aware of, it was unsurprising that busulfan, at I think 3 years the appropriate time point, given the follow-up of patients in the study, was associated with a lower TRM. And the difference is about 6%. It's not a vast amount, but it's definitely there. However, there was a price. There was more relapse in the intravenous busulfan group, and this is about 8 to 9%, again at 3 years. So the two effectively cancel each other out, and I think those survival curves are as close to overlapping as you'll get. So to conclude, pre-transplant conditioning does affect the major outcomes of allograft for ALL in adults. It is important. I think the results of reduced intensity transplant in our really quite large prospective study, we think we're going to have 200 eventually at the end of the study, in patients over the age of 40 are very promising. In our last trial, UKL12, the outcome of patients over the age of 50 was 15%, 15% disease-free survival. So the curves I've showed you really do appear to be better than that. But relapse is a problem, and we need to do further trials to address that issue. The conventional wisdom in ALL is you have to use TBI, and I and Parto Kebriai and various other people are attempting to challenge that assertion. And I think it is worth considering lower toxicity conditioning, such as intravenous busulfan. That appears to be a valid alternative. So I'd just like to acknowledge people in the NCRI ALL group in the UK, my past collaborators on CRBMTR studies, really some household names in transplanting ALL, and also Parto Kebriai for allowing me to use her data. Thanks very much.